So somebody wanted to know about the carotid stump syndrome, and as it's implying, there's a stump in your carotid. So if you have the internal carotid artery, and that's where a lot of occlusive disease is diagnosed with carotid Dopplers. As you know, once you have 100% occlusion, you really can't do anything surgically with that, and you're totally reliant on collaterals at that point. If you've got 99% stenosis, or really 70 to 99, that's kind of be the candidate for stenting or endarterectomy. And if it's critical stenosis and symptomatic, you might have to do the surgery or the intervention emergently. However, once it's 100% occluded, normally we don't have to worry about that. However, there is this one circumstance where you do have to worry about it, and the way it comes to ophthalmology is emboli fly off of the stump and go into the retinal artery circulation and produce either central retinal artery occlusion, branch retinal artery occlusion, or transient monocular vision loss from amaurosis fugax, a TIA of your eye. So it's like the stroke syndromes from emboli from ipsilateral carotid disease, but instead of being stenotic, it's occluded. And the way the stump can still fire up the embolus up into your head is you've got collateral flow. So one of the ways that you could still have collateral flow, and you need that flow because how are you going to get the embolus into the eye without flow? And once you have 100% occlusion, there is no flow. But some patients have what you think is an occlusion, but there's a little trickle of flow. That little trickle of flow can carry the embolus upstairs. The other way is if the flow is going the wrong direction. So instead of going anterograde, it go retrograde, it hit the stump, and it carried the embolus into the external carotid circulation, and then that, through anastomoses, which are all over your face, gets into the central retinal artery occlusion or the branch retinal artery occlusion. So when you have a stump, it could be 100% occlusion, no flow, but if you have trickle flow or collateral flow, including through the external carotid artery, that we call the carotid stump syndrome. And if the emboli are coming from the carotid stump, you might have to separate the stump surgically from the rest of the circulation. And that means ligating that thing. Alternatively, we could do an endarterectomy and open up the external carotid so that it has more flow and divert the flow away from the stump. So when you have a stump syndrome, normally we don't have to worry about 100% occlusion, but sometimes you do have to still worry about it. An ipsilateral embolic event, thromboembolic event from a stump. And that thing we call the carotid stump syndrome.